temporal lobe, and on the right side the disc, and the disc is kind of should snugly occlude the left atrium, and the left atrial appendage would be behind it, and there somewhere, it doesn't matter where, you have to anchor the device. And since we added the hooks there, the anchorage is pretty reliable. I've also had one embolization in about 100 with the hooks, and I had about 10 in 100 without the hooks. So that's the only complication of note we had was embolization, and the hooks decreased that by a factor of 10, plus a bit change in shape. But this position now is actually quite okay, and it's been there now for quite some while. So unless there is a big change when I release this, and it will be okay. So we're ready to release. No, it's okay. Okay, it's released. It stays there. We'll do one more ejection. That looks pretty good. There's still some dye going in, but we can see that we achieved the goal. Maybe we go to protection when the two things are separate. When you move until the disc gets like a line. I cannot move the table myself here, so I'm dependent on somebody. So the other way until the disc, you have to. No, RAO, but no, that's okay. We take whatever. Okay, that's okay. Take this. Yeah, I think that's okay. The left, the anchor will do. I mean, there will be some residual, a little hole there on the other side, but that's okay. It's not the ideal position, but it's an okay position. Okay, so we're finished here. The ECG has come back to normal. If you want to show that. And we move out.
This is actually
if you had a PFO with
great job on it.
If you had a PFO okay, thanks.
As usually,
if you had a PFO, we would now just remove. Well, yeah, I mean, I used two devices which are already not too good. You actually told me to use a smaller one, so I should have listened to you. Okay. Now, if we had a PFO, we just reload it with a PFO occluder device and put that in and close it on the way out, but here we, of course, we don't. And the ECG is now back to normal, as you can see from the screen. Can you show the ECG again?
Bernie, I have a question for you.
Okay, so we're finished with that. Yeah.
Can we take a few questions?
Yeah, sure.
I wanted to know that the transeptal puncture that you did was in the fossa ovalis or slightly below?
I try to be below for two reasons. The one reason is if you're below, you have a straight shot to the left atrial appendage. If you're in the fossa ovalis or even above it, you go along the roof of the left atrial appendage, and then you have to kind of turn 180 degrees. So as low as you can. The other thing is below the fossa ovalis, the septum is thicker, more muscular. So after you pull back the sheet, a muscular septum will close immediately. If you go through the membranous, just a second here. If you go through the membrane of the foramen ovale, you may leave back an ASD, a small one, which of course may also close and is not important because it's at the most 1.52 millimeters. But puncture as low as you possibly can. Now let me just show you one thing here. At home, our patients are awake as this lady. We have a swap here. So she can actually hold her own pressure here. Can you show her groin here? Late answer. Can you bring down your hand here? Can you bring down your hand and press down? You can. Okay, she doesn't want to. But what I usually ask my patients is they bring down their own hand and they just press very lightly, You see, with one finger, just very lightly, and you pull it out. They can just put their own finger. You don't need any pressure in a venous puncture. So I let them hold themselves a little sponge here. I pull it out and I walk away, and they take care of the puncture. When they get up, they can get up from the table immediately. Then they have to hold a bit more pressure because then the weight of the blood the head to here will of course increase bleeding. Lying down in a vein, you have 8 millimeters of mercury pressure. Your index finger is enough to hold that. When you get up, it goes to about 60 millimeters of mercury, then you have to hold a little hard. But the patient can do that easily himself, so there's no need for any help.
Professor Meir? We have a talk on the same topic from Dr. Meir. We are just confirming whether he would like to give the talk right away or after some time, because the case has been going through quite some time. It would be interesting if Dr. Meir can come to the talk so that we can ask more questions.
No, I think Dr. Meir.
Yeah.
Yes.
But Dr. Meir, are you giving the talk now?
All right.
Are you giving the talk now? Can you hear us?
Yeah, I'm ready now.
Okay. Oh, great. Yeah.
I'm just starting up the presentation. And we can go through a few things that we've just seen. So while things are quite hot, what I said is of course, there's still a small risk of embolization of this device. I probably won't, but can you hear me?
Yes, very well, very well.
Can you hear me?
Yes, very well.
Okay. So as I said, with this lady we just did, we need to do an echo before she goes home. She could go home today because it's a venous puncture, or tomorrow. If by transthoracic echo you can see the device, which is not easy to see sometimes, you have to use fluoroscopy to make sure it's still there, looking as it looked when we left it. If it embolizes, which I don't know if it will, she probably will feel nothing because it will go through the heart and stay in the aorta, occlude nothing, but of course then you need to know and to do something about it. Now let me just go through the pictures. I assume you see my slides here, left atrial appendage occlusion.
Yes.
And I go through them. So it's of course atrial fibrillation that will give you the base of the indication, and you all know it's the most common rhythm disorder. Every fourth of us will have atrial fibrillation during lifetime, unless somebody comes up with a remedy in the near future. So that's a lot, and it's a bit more common in women than in men. In India, we estimate now about 6 million people having currently atrial fibrillation, and by the aging of the Indian population, along the aging of all populations in the world, this is going to triple or quadruple by the year 2050, so it's going to be a very, very common thing. Now we all know anticoagulation is needed in atrial fibrillation and in elderly, or if you have additional risk factors, which in Europe is now assessed with the CHADS-VASc score. It was the CHADS score before. Now if you have lots of risk factors, more than 6, then without anticoagulation you have an annual risk of about 10% to have a stroke or a peripheral embolism of significance. If you use warfarin, this risk is much reduced, but it's not zero, as you can see. So you reduce it to about half. And of course, the fewer risk factors you have on top of your atrial fibrillation being permanent or paroxysmal, the smaller your risk, and the smaller the reduction. And there is some point where the bleeding problem, the bleeding risk of anticoagulation no longer warrants that small reduction. But anyhow, in all these people, you should use warfarin. Now we also know that, of course, if you have more risk factors, the stroke risk increases, as we just said. But if the more risky you are in general, the bleeding risk will also be higher. If you're older, if you have hypertension, whatever, those are risk factors for stroke, but they're also risk factors for bleeding. So again, you're kind of between the rock and the hard place. These patients you absolutely need to anticoagulate because otherwise they stroke out. And here you're most afraid of bleeding. So an alternative method that may protect from stroke but have no risk of bleeding is welcome. Now some electrophysiologists in the room may say we take care of atrial fibrillation, we kind of extinct effects of our ablation therapies. It's not, as you can see, it's elected patients with atrial fibrillation, mostly paroxysmal, 2/3 paroxysmal, so those are the easy ones. You see that after a first ablation, only 50% have a durable removal of atrial fibrillation for at least a couple of years. If you use a second attempt, then finally you have a higher, which was necessary in 51% and in 17%, and finally you can see that at the end of 5 years, about 70% are free of atrial fibrillation, but they will come back into atrial fibrillation when they grow older. So it's a temporary measure that works quite well, but it's not a panacea, so we still need to protect from stroke. And then there was this notion that from autopsy surgery and from TEE examinations, that if you have a clot in the left atrium in atrial fibrillation, it is mostly in the left atrial appendage. All these papers meta-analyzed had 17% of clots, and of those 17%, 16% were in the left atrial appendage, and only 1% was somewhere else. This is non-rheumatic atrial fibrillation. If you have rheumatic mitral valve disease, that may also cause clots on the mitral valve and so forth. So it's non-rheumatic, senile, if you will, atrial fibrillation. So 94% of the clots are in the left atrial appendage. So if you exclude that left atrial appendage, you reduce the remaining clot risks to such a little risk that warfarin is no longer warranted, because the bleeding risk is larger than the remaining clot and embolization risk. This is a caricature of a clot in the left atrial appendage. And of course, if you see that by echo, you may not see it by transthoracic echo, by the way, but you see it by TE. And if you go in here to close it and you do an injection here before entering it, you will also see it. So will not by mistake dislocate the thrombus like that may have formed, from the TE to your intervention, or if you have never had a TE, may be there. So there is a certainty even with angiography, as you saw today, that you can make sure that LAA is clean. Now here you see a paper, I think, which is from India, which is very nice in circulation. This group here, maybe the person is in the room, did a TE on a 53-year-old female who had atrial fibrillation. Now she had a stroke 4 hours after this TE. So they thought, did we cause the stroke by the TE? Very unlikely, but they went back and looked more closely at the TE where they had seen this clot. And what they saw is apparently they had missed that while the TE was going on, was that during that TE recording, the clot actually moved out of the left atrial appendage. You see the next picture, it's here. The next picture, it's free in the left atrium, and then it's gone. And 4 hours later, the patient had a stroke because the clot probably got caught up somewhere in bifurcation before it finally went to its final place. That's why it is time lag. But the embolization occurred completely coincidentally during TE. Very nice paper. And now an electrophysiologist of the US, Michael Lesh, was doing left atrial ablation for atrial fibrillation in the early years of this millennium. And then he said, why not, based on all these notions, occlude the left atrial appendage